now invite Dr. Vishali Gupta to give her talk on viral anterior uveitis, pearls from the Titan study.
Thank you very much. Thank you, chairpersons. Thank you, AIOS, for the opportunity. I would be talking about the treatment algorithm networks for infectious uveitis treatment and focusing on the management of viral anterior uveitis. These are the results of the Titan group. So when we come to the herpes, both simplex and VZV, we do understand that herpetic anterior uveitis constitutes about 5 to 10% of anterior uveitis cases. And mostly you would see the granulomatous forms of uveitis. You would have the transmission defects, which are very characteristic for HSV. And you can have sometimes the diffuse transillumination defects as well. When we talk of the herpetic eye disease study that did not answer various questions which are related to the management of uveitis. Now coming to CMV, CMV generally produces high intraocular pressure, mild anterior segment inflammation, and especially if you see these coin-like lesions, they are very, very specific for CMV.
No need.
We also understand acute CMV uveitis generally responds very well to ganciclovir gel or oral ganciclovir, and for chronic, oral is kind of all of us use them depending on our own choice and preference. Recurrence of inflammation is very common once you stop the maintenance therapy. So Sun 2 did a great job in establishing the diagnosis and gave us very clear-cut diagnosis when to diagnose CMV, HSV, or VZV uveitis. So CMV is unilateral anterior uveitis, positive aqueous tap for CMV. HSV is again unilateral with either positive tap, sectoral iris atrophy in less than 50 years, or HSV keratitis. And VZV is unilateral anterior uveitis with either positive aqueous tap for VZV, sectoral atrophy more than 60 years, and concurrent or recurrent zoster, a dermatomal. Now, what I'm going to present you is the results of Titan, which report 1 and 2, where we developed an evidence and experience-based consensus guidelines for the management of HSV, VZV, CMV anterior uveitis to address the lack of international agreement on these conditions. So we had a 2-round online Delphi survey with blinding of the study team. We collected the responses from 76 international uveitis experts from 21 countries, and they were chosen based on more than 15 years of experience in managing uveitis. So the current practices in the diagnosis and treatment of these entities were identified. The working group developed data into consensus guidelines, and consensus was defined as a particular response towards specific question where more than 75% of agreement was achieved within our interquartile range of less than 1. So let's see what was the consensus like. Now, to begin with, let's see how the experts were distributed. Majority of them were from Asia, including India, Southeast Asia, but it had a fairly global representation. Now, let's talk business. So, consensus statement for the management of HSV and VZV, experts agreed that the diagnostic feature as defined by Sun they all agreed on that: unilaterality, increased IOP. They also added decreased corneal sensation and diffuse or sectoral atrophy, because Sun did not talk about these two things. Sectoral atrophy, they felt, was more critical for diagnosing HSV rather than VZV. So regarding the treatment initiation and monitoring, they felt that initiation of treatment for HSV, VZV, anterior uveitis can be administered even when the result of PCR are pending. So you don't have to really wait for the results to start treatment. PCR does give definitive diagnosis, and repeating the PCR for stopping the therapy, nobody recommended. Like, you will base on the resolution of inflammation and the reduction in the IOP. They were the two clinical endpoints for monitoring response to therapy, not the negativity of PCR. Topical corticosteroids would be given both in HSV and VZV, anterior uveitis, and but they would be given only if you have either systemic or topical antiviral coverage. Steroids were the choice, not NSAID. So you don't have to feel that it is viral related anterior uveitis and you would rather treat it with NSAIDs. Experts did not agree to that. Neither periocular nor systemic corticosteroids were considered to have a role. Beta blocker was the IOP lowering drug of choice, both for HSV, VZV, and because of its simpler dosing regimen, oral valacyclovir was preferred systemic antiviral for both. Now, if the patient stops treatment, restarting treatment is necessary only if the disease activity is noted again, and for prophylaxis, it doesn't have a role. Coming to the active corneal involvement, I don't have to go into because herpetic eye disease study already covered it, but experts felt that if there is a corneal involvement, oral antiviral therapy should be considered if not already used, and you have to titrate topical corticosteroids depending on what you have. The problem was chronic and recurrent anterior uveitis due to herpes. So there was a substantial disagreement on the treatment of either chronic or recurrent hypertensive uveitis. 51% of the expert would add long-term maintenance with oral antivirals with or without topical steroids for chronic HSV, and 44 would add for chronic VZV. Now, maintenance antiviral treatment for episodic hypertensive anterior uveitis would be used in 19% for HSV and 18% for VZV. But majority of the experts did agree that if there are 2 or more episodes of hypertensive uveitis per year, at least half of them, 51%, would use a long-term maintenance of oral antiviral. And this discrepancy came, the experts from Asia Pacific, they were all keen to treat it, but experts from Europe and America, they kind of said they will not treat it, but it would be, they do not see much of herpes anterior uveitis anyways. So I think if I have a choice, I would treat them. So this is the algorithm which we have for herpes, that if you have suggestive signs, which is unilaterality, increased IOP, decreased corneal sensation, sectoral or diffuse iris atrophy, look in the past if there are any classical skin lesions present, like the blister, dermatomal distribution. If there is present, just go ahead, start systemic antiviral, topical steroids. Generally, predecetate was preferred, and see the treatment endpoint, reduction in the IOP and the resolution of inflammation. Now, suppose patient has this but doesn't have classical skin lesion, then you consider the aqueous tap for multiplex PCR. If the tap is positive, it's straight away you will start with the treatment, and of course, if IOP is increased, you will add anti-glaucoma. If there is corneal involvement, consider adding topical antiviral. Now, suppose you have started the patient the type of the drugs. If you think it is HSV, then oral valacyclovir 1 gram twice to 3 times a day for at least 2 weeks, or you could use acyclovir 800 milligram 5 times a day for 2 weeks. If it is VZV, then you consider valacyclovir 1 gram TDS for 14 days or acyclovir for 14 days. And the maintenance I have already spoken about. If there are 2 or more recurrent episodes in a year, these are the patients who would merit on maintenance therapy. We are going on to Delphi 3 for the duration of maintenance therapy because the duration was very variable. It varied from 6 months to 5 years. Some people will give for 6 months, average was 1 year, and others will give very long term. We still don't have consensus for that, but hopefully we will. Thank you very much.
Thank you, ma'am. There are two quick questions. Why specifically they wanted beta blocker? Was there any reason? Sub question about that.
Because latinopros per se sometimes can cause the inflammation, and the problem is with brimonidine also, it can induce vasculitis and some granulomatous inflammation. So I think they felt beta and pilocarpine, like nobody uses. So I think they felt beta blocker was the safest one. Though we did have a choice of dorzolamide as well, but majority, this is what they chose.
They chose.
You know, they did not have to give us logic why they chose, but they chose beta blocker.
Ma'am, about CMV, there is a thing that if they have a topical
I had another few slides on CMV, but I don't have time. That's the report number 2.
Okay, so the ganciclovir gel, was there a
CMV ganciclovir gel was the first line of therapy, 0.15%, and they would add systemic therapy, but it was Val-Gan. It was not Val-acyclovir. Systemic therapy if there were recurrences or if the patient had HIV.
So how long they were using for GAN gel for the acute phase and as a maintenance ganciclovir gel?
On an average 3 months, everybody was treating.
Even for CMV?
Yes.
Madam, I wanted a question. Did you look into the endothelial counts also in the study?
We did ask for the specular. Personally, I do specular. You're asking about specular,
specular.
no? I do it for CMV. We did have, but majority of the experts said they will not rely on specular count as a response to therapy. They would rather rely on the lowering of the IOP, decreasing the anti-glaucoma medication, and decrease in the inflammation.
You personally feel endothelial count is lesser? I mean, in your experience in CMV?
Yes, it comes back also.
It comes back also.
Yeah. But it's not that I do it for every patient. It doesn't guide me. But if you do it, it's fun to see the specular count is low. Or if you can, like Padma Malini can do confocal, our cornea people take hours to do it and they don't do it with pleasure. So, you can't rely on them. But if you see those owl-like inclusions, if you see low specular count, then it's kind of substantiates the diagnosis of CMV.
Okay. Anybody in the audience has any questions?
I just have one question, ma'am. In viral anterior uveitis, most of the times we see descending membrane folds and pigmented KPs. Do you think these are important? It was not included in the thing?
They are important, but they are not very diagnostic only for viral anterior uveitis. So these are the features which are more that take you in that direction. Because corneal folds can be seen in lot of acute uveitis where the IOP has really gone down due to ciliary body shutdown. So it's an important feature, but it's not, experts felt it was not very
so
specific for viral.
Okay.
Thank you.
You'll not be able to get her, so any more questions? He's going to the Retina Symposium next.
Thank you.